After performing the surgical hand scrub, hands should be kept up. Why don't you show us the positions, how to keep it, and why it should be done? Why?
It should be like this.
It should be like this.
Why?
So that
Yeah.
This is this is contaminated part, and whatsoever water which is trickling down, it should not go.
So it has
against
to
this.
trickle down. It should not.
It's the most sterilized part, uncontaminated part. This is contaminated. So we have to keep our hands like this, so that if water which is poured over this part, it should go away from.
So it should trickle down to your elbow, which is the most contaminated part. Abdomen should not be saved. In the morning we discussed about that. In how many centers, let it be, there are around at least 12, 14 medical colleges. In any center where abdomen is not saved. Bansal, abdomen not saved in any cases? Saurabh, Dr. Saurabh? No shaving, very good. Hair clipping. So 2, we have to advocate that. We have to advocate that. Time has changed. Unless otherwise we start practicing, we can't preach.
Yes, what happens in shaving, we may have cuts over the skin. अपन लोग अपनी दाढ़ी भी बना लेते हैं या कहीं पे भी तो हल्के से cuts लग जाते हैं. That is a source, that is entry point for infection. So we have to minimize this. So somehow we have to bring that good practices.
The sterile objects and persons in surgical attire, stop team are allowed within the field. कल ही मुझे किसी ने बोला कि जो मेडिकल सुपरिटेंडेंट थे ये ओटी के अंदर घुस गए to check whether the surgeon is in good attire or not. And actually C suspended one of the nursing staff that C was not in good attire. So if this is the attitude, then we have to make them more wise and more intelligent.
In fact, वहाँ पर शायद जो ओटी नर्स होगी, probably वो खुद का काम नहीं जान पा रही होगी. Otherwise, ओटी नर्स के अनुमति के बिना कोई भी सर्जन या कोई भी व्यक्ति ओटी के अंदर विदाउट चेंजिंग जा ही नहीं सकता है. हो सकता है कि कुछ डर के कारण MS साहब को वो रोक नहीं पाई. This simply means that she doesn't know what she has to do. So we have to educate, or she has to exercise her powers.
Moving to how to clean and disinfect. A clean operating environment is essential to prevent SSI. There should be no dust in the OT. Lint containing textiles and floor mops can be the source of dust. OTs must be cleaned daily. Now I would like to make your attention to this particular point. OTs must be cleaned daily before first surgery, after each surgery, and at the end of the day. And what to clean? The cleaning should be OT table, furnitures, lights, equipments, window sills, ledges, scrub rooms and sinks. Possible after each surgery?
No, cleaning of OT is possible, but not OT tables. And if it is soiled, visibly soiled, it should be cleaned. And of course, the furnitures we are not using, lights if it is soiled. Equipments, of course, we have to replace the equipments and replace it with sterile ones. Window seals, no.
This is a guideline. As much as we can adhere, it will be okay for us, or it is good for us. So we should try to adhere as much as possible and practicable. Thorough cleaning of the entire OT should be done at least once. Terminal clinic on every Saturday is a practice in my institute.
Yes, it is done in most of the institute, I think, in weekend days. जैसे Sunday की छुट्टी रहती है तो Saturday afternoon. In our hospital we suspend everything. 12 बजे तक के जो होना है बाकी का emergency OT में shift कर लेंगे. And that routine OT is.
Components of the operation theatre and OT. The OT and operation room is a multifunctional area. In this area, patients are received, prepared for surgery, operation team prepares for surgery, blah blah blah. Equipment cleaning, processing and sterilization should be done in centralized area, CSSD. How many medical colleges has a central sterilization unit, CSFD? 1, 2, 3, oh, many.
Most of.
Most of them. Very good. One CSFD staff was there. Yeah. The OT areas are distributed into zones depending upon the level of sterility and cleanliness. I would like to get some more advice from our surgeon friend for this color-coded NCDC chart. Actually, there are 3 areas: clean areas, sterile area, and there are some disposal zones. If you look at, they have tried to identify which areas should be at which place. Why don't you show us some more light, sir? This is the light green is anesthetic induction. 2 anesthetic induction sites are there. Then cleanup area, scrub area, and the operating rooms would be as much sterile as possible. That is in dark green. And after that, there is a sterile stock store for all those like your anesthetic medications, catheter, Foley's, and all.
So usually in OTs it is followed that whenever the person is coming from outside, he or she has to put off his shoes. So that is unrestricted zone, and beyond that we had to line that. Then the surgeon or that OT staff is entering into clean zone. And there is some semi-restricted zone where each and everybody cannot be roam around. And now the restricted zone or sterile area, it is strictly sterile. उसके बाद scrub करके ही आगे जा सकते हैं. या तो OT staff जो बिल्कुल अंदर के अंदर ही वो जो sterile instruments और sheets वो provide कर रहा है वही जा सकता है. तो that is sterile. और एक disposable zone और area वो रहता है back of the OT in well formed OT. तो दैट इज नॉन अ स्टेराइल जोन. जो भी ओटी के अंदर जो भी स्पिलेज होता है या सामान रहता है या जो भी निकलता है बायोहजार्डस वेस्ट, तो एक विंडो रहता है, उससे डायरेक्टली उसको डर्टी कॉरिडोर बोलते हैं उसको. वहाँ पे एक अलग ही वो चलता है. वो सब जो ओटी के अंदर की सिस्टर है वो उससे बाहर करते हैं. दैट इज सेंट आउटसाइड द ओटी थ्रू अ सेपरेट पाथ.
If you look at the legend in red, separate and clearly defined functional and decontamination areas are required to maintain effective barrier for infection control. So everybody should be knowing this is the restricted, semi-restricted, and absolutely sterile zone that is to be mandated and probably color coded.
Yes, there is color coding as well as each and everybody should know all these things. जो कि पिछली बार का सवाल था, एक MS साहब अंदर चले गए थे, तो शायद probably he also is not knowing about this thing. Otherwise he would not have entered into that area.
Functional and decontamination areas in OT. Functional areas can be recognized by extreme high, medium, and low risk. Both functional and decontamination areas should have adequate lighting for the minimization of the risk, enable inspection of the cleaned areas and equipment, good ventilation to reduce the risk of cross-infection, smooth impervious work surface made from non-porous material, slip-resistant, non-slip, water impervious flooring with sealed joints, correct beams.
Yes.
Most of the OTs will be having all this, all our OTs. The matter of debate, why I called my friend, the friend from the surgery department for this only. Surgical antimicrobial prophylaxis. When we teach our students, we teach that surgical antimicrobial prophylaxis should be given at least 60 minutes or within 120 minutes prior to surgery, so that the antibiotics should have a maximum concentration at the tissue level at the time of incision. It should not be going beyond 24 hours in any case. But all of us knows it goes beyond sometimes 5 days, 7 days. What's your take and how to move on from here?
In cases of routine surgeries, if the patient is settled, he doesn't have any problem. So in our setup, we used to give prophylactic antibiotic 1 hour prior to surgery, or if at all it is cannot be done, so at the time of induction. so that when we give incision, we can have a maximum concentration of antibiotics in the bloodstream, as well as to minimize any type of other infections.
Sir, you personally choose which antibiotic for surgical prophylaxis or a intra-abdominal infection? Let it be you are planning for a open coli. What will you choose?
I have two experiences. So even our this penicillin augmentin, that has a very good coverage. And pardon?
Cefazolin is in the guideline.
Yes, so cefazoline that was used previously, and what my experience is that even a single dose of ceftriaxone sulbactam is sufficient for a day case surgery.
If you look at
Not going beyond this.
most of the guidelines, it mentions cefazolin whenever the skin is breached. Cefazolin is not, cefazolin or cephalexin are not usually available. And recently the guideline says if the patient is in sepsis, you can move for cefoperazone. For that matter, it has to be sepsis and septic shock. For routine, with some gram-positive cefazolin or cephalexin are okay, but we don't practice it. I do not know. If you look at any international guideline, everything will mention about cefazolin versus cephalexin. Cephalexin to some extent available, cefazolin is not at all available. Many a surgeon start with ceftriaxone, cefoperazone depending on plus minus. I think this is time to think about it, how to move.
I think cephalexin is not an IV form.
No, not an IV form. Not an
It's
IV.
oral formulation is like.
Does the choice depend upon the
Clean and-
contaminated surgery?
That's why I told you that routine surgery.
Fine. So if you look at definitely the surgical antimicrobial prophylaxis, you can talk for a day. There is a beautiful guideline from WHO that recommends for prevention and treatment of maternal. I was talking about this one. Global guidelines for the prevention of surgical site infection by WHO. I would like all the anesthetist and surgery friends to go through this document to have how to have less number of SSIs. Thank you, sir, to accommodate us for the surgery